Dr. NIKHITA presenting a case of rare neurological emergency detected in ophthalmic OPD. We all know that signs of raised intracranial pressure coming to ophthalmic OPD will be papilledema, bilateral sixth nerve palsy and headache. Patient mainly come to the ophthalmologist first with headache and diplopia. So proper evaluation is must to detect the neurological emergencies like intracranial space occupying lesions like tumors, hemorrhages or idiopathic intracranial hypertension, cerebrosinus venous thrombosis and meningitis, etc. So I present a rare case of papilledema along with bilateral sixth nerve palsy, which was reported in a young female, detected and treated immediately, saving her life. A young 17-year-old female came with headache since 1 week associated with nausea, dizziness and had 2 episodes of vomitings. She complains of double vision since 1 day. She said that doubling of images disappears when she closes one eye. She had no history of fever, head trauma. She had history of menorrhagia since 3 months and was taking hormone pills for the same as prescribed by her gynecologist. Patient was well oriented and her vitals were stable. Systemic examination was normal. Coming to ocular examination, her vision was 6/6 in both eyes. Color vision was normal. Abduction restriction was noted partially in both eyes, suggesting bilateral sixth nerve palsy. Anterior segment was normal. Fundus examination show early papilloedematous changes in both eyes. Fundus, right eye fundus showing early both eyes showing early papilloedematous changes. So there was a suspicion of raised intracranial pressure as patient had bilateral papilledema with bilateral sixth nerve palsy. Immediately patient was sent for MRI with MRA or MRV and the report showed cerebrosinus venous thrombosis of superior sagittal sinus. Her thrombophilia and blood profile for protein C, protein S, homocysteine, antithrombin 3, etc. was sent and reports were negative. Her coagulation profile was normal. CSF analysis was normal. Patient was immediately referred to neurology and treated with anticoagulants, that is IV low molecular weight heparin, acetazolamide and other symptomatic treatment was given. So this case was a hormonal pills induced cerebrosinus venous thrombosis which causes raised intracranial pressure, and patient was advised to stop hormonal pills. After treatment for thrombosis, fundus becomes normal and diplopia was recovered due to decreased intracranial pressure and patient becomes normal. Discussion. Bilateral papilledema suggests there is raised intracranial pressure, but association of bilateral sixth nerve palsy is a rare clinical consequence, may be associated with its severity. The patient had severe headache and did not have any other cranial nerve abnormality except sixth cranial nerve and had features of papilledema suggesting the localization to the subarachnoid space and possibility of raised intracranial pressure. Sixth nerve is more vulnerable to raised ICT because it gets compressed in the subarachnoid space as it takes acute bend at to enter into Dorello's canal. Hence, bilateral transient sixth nerve palsy is a false localizing sign. This young female had history of usage of hormonal pills for gynec problem for a period of 3 months, which leads to the suspicion of a thrombosis, and hence MRI with MRA or MRV was advised, confirming cerebrosinus venous thrombosis. CSVT is a rare life-threatening condition, most common among females. Risk factors include severe dehydration, hormonal pills usage, pregnancy, otitis media, mastoiditis or any other clotting factor abnormalities. So immediate anticoagulation therapy can resolve the thrombosis, decreasing the intracranial pressure within few weeks, saving the patient's life. So my conclusion was dilated fundus examination is must to look for papilledema to rule out raised intracranial pressure in patients presenting with diplopia and severe headache. So it may save the life from neurological emergencies. Timely anticoagulant therapy in this case contributes to the good clinical outcome. Thank you.
Thank you, Dr. that concludes this session. Thank you all very much.